Okay, you've given us a stack of material, a real deep dive request into the fascinating, complex world of liver and gallbladder pathology. Think of this as us putting on our elite professional hats, the kind who really master the details and walking through these sources together.
That's right. We're going to meticulously unpack everything here, from the fundamental ways the liver gets injured and tries to repair itself, all the way through specific diseases like viral hepatitis, genetic conditions, circulatory problems, and everything you need to know about the gallbladder, especially gallstones.
Yep.
Our mission today is total immersion, covering every single concept and topic in your material so you can truly own this knowledge.
Exactly. We're not just skimming the surface. We're going deep on every point, connecting the dots and pulling out those critical nuggets. This is your shortcut to mastering this field. Ready? Let's jump into this deep dive. So, where do we start? Let's appreciate the star of our show, the liver. This is a pretty substantial organ, weighing in at, 1,400 to 1,600 grams in an adult.
Right around there, yeah. And what's absolutely critical for understanding liver disease is its unique blood supply. It gets a dual feed.
Dual feed, how does that work?
Well, about 60–70% comes from the portal vein, which is loaded with nutrients, but also, potential toxins, absorbed straight from the gut. The rest comes from the hepatic artery, bringing the oxygenated blood.
Oh, okay.
This dual supply makes it incredibly resilient, but it also means trouble can come from multiple directions.
Which it totally does. This material shows just how vulnerable the liver is to a huge range of problems. Metabolic issues, chemical toxins, microbial invaders, circulatory blockages, cancers.
And it acts like a filter, too.
Right, so diseases starting elsewhere like heart failure or widespread cancer can hit it secondarily.
Now, here's one of the most important insights right off the bat. The liver has this massive functional reserve. You can lose a significant portion of your liver function before you feel anything.
So liver disease can be silently progressing for a long time. That's kind of scary.
Precisely. It's often insidious. Clinical symptoms and signs of liver failure might not show up until weeks, months, or even years after the initial injury begins.
Wow.
This means the first hint you often get that something is wrong are just abnormal lab tests.
Ah, the labs. The source points to a few key tests: serum albumin, coagulation factors like PT-PTT, and ammonia. In the context of liver disease, how do these typically change?
Okay, think about what the liver does. It synthesizes albumin and clotting factors, right? Like fibrinogen, prothrombin factors V, 7, 9X.
Right, lots of them.
So when the liver's damaged, its synthetic function decreases. That means decreased serum albumin. And because clotting factors are low, the PT and PTT times will be increased. Blood takes longer to clot.
Okay, longer clotting time. Makes sense.
On the flip side, the liver normally clears substances like ammonia from the blood. With liver failure, that clearance is impaired, so ammonia levels go up.
Right, and metabolic tests.
And tests that measure liver metabolism, like the aminopyrine breath test, they show decreased activity.
Okay, let's go microscopic. How do the liver cells, the hepatocytes, react to injury in those early, maybe reversible stages?
Well, the hepatocyte has a few key defensive postures, you could say. It can start accumulating fat that's called steatosis.
Fatty liver.
It can build up bilirubin, leading to cholestasis. And it can swell up, its cytoplasm clearing, and intermediate filaments clumping together, that's ballooning.
And when that clumping of intermediate filaments is really prominent, we call that Mallory hyaline. The material flags that as a hallmark.
Yes, absolutely. Mallory hyaline is a key histologic feature of ballooning, though it's not specific to just one cause. You see it often in alcoholic liver disease and other conditions causing severe hepatocyte stress. It's a sign the cell is really unhappy.
Now, let's think about the liver structure, the lobules, the acini. How does this structure influence where injury happens?
This is where zonation comes in. It's really important. The liver has these units, historically called lobules, centered on central veins, or functionally, as acini based on blood flow from the portal tracts at the periphery towards the central veins. Okay. Hepatocytes differ depending on their position relative to the blood supply. Cells closer to the portal tracts in zone 1 get the most oxygen and nutrients.
Makes sense. First dibs on the blood.
Exactly. Cells around the central vein in zone 3 are relatively hypoxic, less oxygen, but they have high levels of certain metabolic enzymes like the CYP450s.
So, different toxins or problems might hit different zones first, depending on oxygen needs or where metabolism happens.
Exactly. Toxic or ischemic injuries often target zone 3 because of its lower oxygen and high metabolic activity. Think acetaminophen overdose classic zone 3 necrosis. Zone 1 might be more susceptible in certain inflammatory conditions. Understanding this zonation really helps interpret injury patterns you see on a biopsy.
What happens when the injury goes past that reversible stage? When the cells actually die?
That's when hepatocytes start to die, either through necrosis or apoptosis. This loss can follow different patterns. You might see scattered individual cell death with cleanup cells, macrophages rushing in, that's spotty necrosis or apoptosis.
Just scatter damage.
Right. Or you can get contiguous loss of cells in a zone, confluent necrosis, frequently starting in zone 3.
And that can spread, right? Connect areas.
Yes, you can get bridging necrosis, connecting central veins to portal tracts, or even portal to portal tracts. In really severe cases, the entire lobule can be wiped out, panacinar or panlobular necrosis.
Wow, total wipeout.
Yeah, and the material notes that even viral infections, which might initially cause just spotty death, can lead to large areas of necrosis if there are secondary issues like vascular compromise.
And when you have extensive cell loss and the underlying support structure collapses, that's where scarring comes in.
Right, the reticulin framework collapses. And if this scarring is diffuse, widespread, combined with attempts at regeneration that create these abnormal nodules, you end up with cirrhosis.
Cirrhosis, the end point for a lot of chronic liver problems.
Exactly. The source defines it as diffuse remodeling of the liver into parenchymal nodules surrounded by fibrous bands, often with vascular shunting. The blood flow gets rerouted abnormally. Grossly, it looks bumpy, shrunken.
Yeah.
Histologically, you see those thick fibrous septa dividing the nodules.
It sounds like once you're at cirrhosis, that's it, game over for repair. But the material mentions scar regression is possible. That sounds new.
Yes, this is a relatively newer understanding, and it's quite important. Historically, cirrhosis was considered pretty much irreversible. However, research shows that with effective treatment of the underlying cause, like, say, curing hep C or stopping alcohol completely, some degree of scar regression can occur.
Really?
Yeah, although significant architectural changes often remain. But it offers some hope in what was previously seen as a point of no return. It's not always a one-way street.
Moving from the microscopic to the major clinical problem.
Yeah.
Liver failure. This is
Okay.
a big one, right?
It is. Liver failure represents the severe loss of liver function. It can happen acutely from a sudden insult, chronically from progressive damage over time, or as an acute event layered onto pre-existing but compensated chronic disease, acute-on-chronic.
Let's break down acute liver failure first. How is it defined precisely?
Okay, acute liver failure is diagnosed when you have an acute liver illness, typically developing within 26 weeks of the initial injury accompanied by brain dysfunction, which we call encephalopathy.
Brain fog, confusion, coma.
Exactly. And a problem with blood clotting, coagulopathy. But the key defining point is that this happens in someone who had no pre-existing chronic liver disease. Usually the onset is quite rapid, often within 8 weeks of the injury starting.
What does the liver actually look like in acute failure?
The characteristic finding is massive hepatic necrosis, widespread death of liver tissue, leaving only islands of preserved or maybe regenerating cells. The liver itself is often small and shrunken.
Not enlarged.
No, often small because so much tissue has died. Histology shows broad areas of dead cells, like that zone 3 necrosis from acetaminophen we talked about. Toxic injuries like acetaminophen are very fast. Viral causes develop over weeks, giving a bit more time for some reaction.
The source notes some rare cases of acute failure without obvious cell death, just dysfunction. How does that happen?
Ah, yes. That's often due to problems with the hepatocytes, mitochondria, the powerhouses. This leads to diffuse microvesicular steatosis, tiny fat droplets filling the cells, impairing function without immediately killing them.
So the cells are full of fat, but not dead yet.
Right, initially. Examples include fatty liver of pregnancy, reactions to certain drugs like valproate or tetracycline, and Rey syndrome. The liver is dysfunctional, failing, but the cells aren't structurally destroyed right away.
And viruses not usually known for liver damage can cause it too in certain people.
Yes, in immunocompromised individuals, non-hepatotropic viruses like CMV, HSV, and adenovirus can cause severe hepatitis and acute liver failure. Their immune system can't control these viruses effectively.
The material gives us a mnemonic for the causes of acute liver failure. AF. Let's run through that for mastery. Really nail it down.
Great idea. It's a good way to remember the major culprits.
Acetaminophen, #1 cause in the U.S. Also hepatitis A and autoimmune hepatitis.
Okay.
B. Hepatitis B.
B.
C. Hepatitis C, less common cause of acute failure, more chronic. And cryptogenic, meaning cause unknown, though often it turns out to be an undiscovered drug injury or something else.
Okay.
D, drugs and toxins, besides acetaminophen and hepatitis D,
B.
hepatitis E, and esoteric causes. This covers less common things like Wilson disease, Biliary, or malignancy infiltrating the liver.
Esoteric.
Fatty change, specifically the microvesicular type we just mentioned, seen in things like fatty liver, pregnancy, Ray's syndrome, and some drug toxicities.
A, B, C, D, E, F.
Got it. That's a comprehensive list. And the consequences of acute liver failure, they sound incredibly severe.
They are life-threatening. Because the liver isn't making clotting factors, you get severe coagulopathy, massive bleeding risk.
Toxins build up, especially ammonia, leading to hepatic encephalopathy, affecting the brain, confusion, disorientation, coma.
Yeah.
Portal hypertension can develop rapidly. Pressure builds up, leading to dangerous bleeding from esophageal varices.
Oh, wow. Even acutely.
Yes, and the liver failure can also trigger kidney failure. That's hepatorenal syndrome or even high blood pressure in the lung vessels, portopulmonary hypertension, some multi-system collapse.
So acute failure is sudden, dramatic, while chronic liver failure is the slow burn, usually culminating in cirrhosis.
Exactly. Chronic liver failure is most commonly the result of that advanced fibrosis and cirrhosis we discussed earlier. It's that end stage where the liver is remodeled into nodules surrounded by thick, fibrous bands with significant disruption of blood flow and function.
And what are the main drivers of chronic liver failure and cirrhosis worldwide? Is it the same everywhere?
Globally, chronic hepatitis B and hepatitis C infections are huge drivers. In the Western world, though, non-alcoholic fatty liver disease, NAFLD, and alcoholic liver disease are the dominant causes now.
Yeah, NFLD is massive.
It really is. The source points out that chronic liver disease is the 12th leading cause of death in the U.S., and most of these deaths are due to the complications of cirrhosis.
And symptoms here are also often late, still that silent progression.
Very much so. Around 40% of individuals with cirrhosis are asymptomatic until the disease is quite advanced. When symptoms do appear, they are initially nonspecific: fatigue, nausea, weight loss. It's often vague.
So what pushes someone with compensated cirrhosis into actual failure?
Often it's a superimposed stressor, like a severe infection. Sepsis is a big one. Heart failure worsening, another drug injury, or the development of liver cancer, either HCC or cholangiocarcinoma within the cirrhotic liver.
One of the most feared consequences of cirrhosis is portal hypertension. What's the mechanism there, simply put?
Portal hypertension is just high pressure in the portal venous system, the big vein bringing blood from the gut to the liver. It's usually caused by increased resistance to blood flow through the liver.
Because of the scarring.
Exactly. Most commonly, it's the architectural distortion and fibrosis seen in cirrhosis, blocking the normal pathways.
And the body tries to find detours around this blockage, like traffic finding side streets.
Precisely. Blood gets diverted through alternative routes, creating portosystemic shunts, where blood from the portal system connects directly into the systemic circulation, bypassing the liver filtering process.
And the material details the principal sites where these shunts occur. Where are they?
Okay, key locations. At the esophagogastric junction, forming esophageal and gastric varices. These are incredibly significant because they are thin-walled and prone to rupture.
Leading to massive bleeding.
Yes, life-threatening bleeding. Occurs in about 40% of patients with advanced cirrhosis. Each bleeding episode has about a 30% mortality rate. Really dangerous.
Wow.
Other sites include around the rectum, causing hemorrhoids, in the retroperitoneum, and along the abdominal wall via the falciform ligament. That last one can cause those prominent dilated veins around the navel known as caput medusae.
So variceal bleeding is the big acute danger of portal hypertension. What are the other consequences?
Congestive splenomegaly, the spleen gets enlarged because blood backs up into it. And hepatic encephalopathy caused by toxins like ammonia bypassing the liver's detox function via those shunts and reaching the brain.
And finally, acute-on-chronic liver failure. Is that just an acute worsening of someone with pre-existing chronic disease, like that superimposed stressor idea?
Yes, exactly. It's a sudden decline in liver function in an individual who already has compensated chronic liver disease.
Yeah.
An acute insult infection, alcohol binge, drug toxicity, surgery pushes the already compromised liver over the edge into overt failure.
Let's transition now to diseases of bile flow, or cholestatic disease. What exactly is cholestasis?
Cholestasis means impaired bile flow and retention of bilirubin and other substances normally excreted in bile, like bile salts. This can be due to the liver cells not forming bile correctly, or some kind of obstruction in the bile ducts preventing flow out of the liver.
Okay. To understand that, we probably need a quick recap of how bile and bilirubin are handled. The source gives a good summary.
Right. Bilirubin is a breakdown product of hewarum, mostly from old red blood cells. This initial form, unconjugated bilirubin, travels bound to albumin in the blood to the liver.
Okay, it's delivered to the liver.
Inside the hepatocyte, it's taken up and then conjugated, chemically modified with glucuronic acid by a specific enzyme, UGT1A1, located in the ER. This makes it water-soluble.
Conjugated bilirubin. Got it.
This conjugated bilirubin is then actively pumped out of the hepatocyte into the tiny bile canaliculi, the start of the biliary tree.
Then it goes to the gut through the bile ducts.
Exactly. In the gut, bacteria deconjugated it back into urobilinogens. Most of these urobilinogens are excreted in the feces, giving them their characteristic brown color.
Okay.
A small amount is reabsorbed, goes back to the liver via the portal vein, and is re-excreted into bile. A tiny fraction escapes into the general circulation and is excreted by the kidneys and urine.
What about bile salts? They're important too, right?
Crucial. Bile salts are made from cholesterol in the liver. They are also conjugated, usually with taurine or glycine. They act like detergents, essential for digesting and absorbing fats and fat-soluble vitamins. They form micelles with cholesterol and phospholipids to keep cholesterol soluble in bile.
And they get recycled.
Very efficiently. Most bile salts are reabsorbed in the terminal ileum and returned to the liver via the portal blood, that's the intrahepatic circulation. The liver just has to make up the small amount lost in feces.
So when any part of the system breaks down, you get jaundice from hyperbilirubinemia. The source differentiates between unconjugated and conjugated types. What causes predominantly unconjugated hyperbilirubinemia?
Okay, think upstream problems. Either you're making too much bilirubin, like massive hemolysis, breakdown of blood from internal hemorrhage, or ineffective erythropoiesis where red cell precursors die in the marrow.
Too much production.
Or the liver isn't taking it up properly. Some drugs can interfere with that. Or, the big one, impaired conjugation. The UGT1A1 enzyme isn't working well.
Like in newborns.
Exactly. Physiologic jaundice of the newborn is common because UGT1A1 activity is low initially. Breast milk jaundice involves substances in breast milk inhibiting conjugation. And then there are genetic defects in UGT1A1, the Crigler-Najjar syndromes, and Gilbert syndrome.
And predominantly conjugated hyperbilirubinemia, what causes that?
This means the bilirubin got conjugated okay, but it can't get out into the bile ducts properly. So think downstream problems. It could be inherited defects in the transporters that pump conjugated bilirubin into the bile canaliculus, that's Dubin-Johnson and Roeder syndromes.
Okay, pump problems.
Or widespread hepatocellular disease that disrupts the bile canaliculi, like severe hepatitis or cirrhosis. Or, very commonly, an actual physical obstruction of the bile ducts somewhere along the line.
Physiologic jaundice of the newborn is mentioned as a common unconjugated one, usually transient.
Yes, it's normal. Usually resolves in the first week or two as the liver matures its enzyme systems.
Let's look at the hereditary hyperbilirubinemias. Crigler-Najjar and Gilbert sound like increasing severity of that UGT1A1 enzyme problem.
They are, exactly. Crigler-Najjar type 1 is a severe, near-total absence of UGT1A1 activity. Leads to extremely high unconjugated bilirubin, brain damage called kernicterus, and it's often fatal early in life without aggressive treatment, like phototherapy or transplant.
Wow, severe.
Type 2 is a milder deficiency, still significant unconjugated hyperbilirubinemia, but usually responds to drugs like phenobarbital that can induce the enzyme activity. Gilbert syndrome is different. It's a very common, very mild defect in UGT1A1 promoter, causing slight unconjugated hyperbilirubinemia, often noticeable only during stress, illness, or fasting. It's essentially harmless.
Just a genetic quirk, really.
Pretty much.
And Dubin-Johnson and Roeder, they cause conjugated hyperbilirubinemia.
Yes, these are different. They're autosomal recessive defects in the transporters that move conjugated bilirubin out of the hepatocyte into the bile. Dubin-Johnson is due to a mutation in the MRP2 transporter. A classic feature is that it causes the liver to accumulate a dark, melanin-like pigment, making it look black grossly, though clinically it's usually benign.
A black liver, that's memorable.
It is. Roeder syndrome is similar, clinically conjugated hyperbilirubinemia, but the transporter defect is different, and there's no liver pigment. Both are generally innocuous conditions.
So that covers problems with bilirubin formation or processing. What about problems with bile flow, like large bile duct obstruction? What blocks the big pipes?
If a large duct, like the common bile duct, gets blocked, bile backs up into the liver. In adults, Common causes are gallstones that have escaped the gallbladder and gotten stuck in the common duct that's choledocholothesis.
Gallstones on the move?
Exactly. Or tumors pressing on or growing in the ducts. Pancreatic head cancer is a classic one. Or cholangiocarcinoma itself. Surgical injury can cause strictures, scarring that narrows the duct, or diseases like primary sclerosing cholangitis cause inflammation and strictures.
And in kids?
Key causes are different. Biliary atresia, where the ducts didn't form properly or get destroyed early. Cystic fibrosis, where thick secretions can plug ducts. Or choledochal cysts, which are congenital dilations of the ducts.
If the obstruction is cleared, can the liver recover? Say you remove the stone.
Yes, if the obstruction is relieved relatively early, the cholestasis and liver injury can reverse. But if it persists, the backup pressure and retained bile salts cause ongoing damage to the bile ducts and liver cells, leading to inflammation, fibrosis, and eventually a specific pattern called biliary cirrhosis.
And bile just sitting there seems like a perfect setup for infection.
Absolutely. Stagnant bile is a great growth medium for bacteria. Obstruction strongly predisposes to ascending cholangitis bacterial infection traveling up the bile ducts from the gut, usually enteric organisms.
Sounds serious.
It is. Typically presents with fever, chills, right upper quadrant pain, and jaundice-Charcot's triad. Severe cases can lead to liver abscesses, sepsis, and can be fatal if not treated promptly with antibiotics and drainage of the obstruction.
The source also mentions cholestasis of sepsis. Is that due to bacteria in the bile ducts too?
Not necessarily primary infection of the ducts themselves. Cholestasis sepsis is more of a liver dysfunction that happens as part of the body's systemic response to severe infection somewhere else, particularly gram-negative bacteria sepsis.
How does that work?
It's thought to be due to circulating microbial products like endotoxin or inflammatory cytokines that directly affect hepatocyte bile formation and the function of those transporter pumps we talked about. Plus, maybe some component of reduced blood flow or ischemia during sepsis.
And how does that look microscopically? Different from obstruction?
You do see bile plugs in the canaliculi, like in other cholestasis, but a notable feature often described is the accumulation of bile in the small ducts near the portal tracts, and the canals of Herring, what's termed ductular or cholangiolar cholestasis. The liver cell injury and inflammation might be relatively mild compared to direct obstruction.
Okay. Primary hepatolithiasis, or recurrent pyogenic cholangitis, sounds like another stone issue, but inside the liver ducts this time.
Yes, this involves the formation of stones, usually pigment stones, within the intrahepatic bile ducts, the smaller ducts inside the liver itself. It's especially common in East Asia, for reasons that aren't entirely clear.
And the consequences.
These intrahepatic stones cause repeated bouts of bacterial cholangitis, chronic inflammation, and progressive destruction of liver tissue around those ducts. It's also a significant risk factor for developing cholangiocarcinoma in those affected ducts.
Moving to kids, neonatal cholestasis. Jaundice after 2 weeks is a red flag, you said.
Correct. While mild jaundice is common in newborns, persistent jaundice beyond 14-21 days needs investigation. The causes fall into two broad categories: obstructive problems, where bile can't get out, and non-obstructive problems related to liver cell function or smaller duct issues.
And extrahepatic biliary atresia is the major obstructive cause in infants.
It is, sadly. It's the most common cause of neonatal cholestasis requiring surgery and the leading reason for pediatric liver transplant. It's a progressive inflammatory and fibrosing process that destroys and obstructs the extrahepatic bile ducts, the large ducts outside the liver, usually within the first 3 months of life.
What causes it?
The most common form, the perinatal type, starts after birth, and the cause is still unknown. Maybe viral or autoimmune triggers are involved. There's also a less common fetal form associated with other developmental abnormalities. It presents with jaundice, dark urine, pale stools, because bile isn't reaching the gut, and an enlarged liver.
What does it look like pathologically?
You see inflammation and fibrosis obliterating the extrahepatic ducts, and this process extends up into the intrahepatic system. Liver biopsy shows the classic features of biliary obstruction: portal edema, swelling, proliferation of small bile ducts trying to compensate ductular reaction, and often neutrophils. If uncorrected surgically, like with the Kasai procedure, it rapidly leads to biliary cirrhosis, often by 3 to 6 months of age.
And the non-obstructive causes of neonatal cholestasis, you mentioned genetic syndrome.
Yes, these are diverse. Alagille syndrome is a key one. It's autosomal dominant, caused by mutations in genes like JJG1 or NOTCH2, which are part of the Notch signaling pathway crucial for bile duct development.
So a developmental pathway problem.
Exactly. It causes cholestasis because there's a paucity, a lack of intrahepatic bile ducts, but it also affects other systems relying on notch signaling, leading to characteristic facial features, butterfly vertebrae, eye defects, and heart problems.
A multi-system genetic disorder? What else?
Other non-obstructive causes include various inborn errors of metabolism that affect liver function, like galactosemia, Niemann-Pick disease, alpha-1 antitrypsin deficiency, which we'll cover more later, and specific genetic disorders of bile acid synthesis or transport. Then there's what used to be called idiopathic neonatal hepatitis.
Idiopathic meaning cause unknown. What are the features there?
It's characterized by liver cell injury, inflammation, and cholestasis. A distinctive histological feature often seen is the presence of multinucleated giant hepatocytes, where several liver cells fuse together. But, as the material notes, with advances in genetic and metabolic testing, the underlying cause can now be identified in a large majority, 85–90% of neonatal cholestasis cases, significantly reducing that idiopathic category.
That's significant progress. Let's move to autoimmune diseases that target the bile ducts. Primary biliary cholangitis, PBC, and primary sclerosing cholangitis, PSC. How do they differ?
They're both autoimmune conditions affecting the biliary system, but they are quite different in their targets, who they affect, associations, and pathology.
Okay, let's start with PBC.
PBC is an autoimmune disease primarily targeting the small and medium-sized intrahepatic bile ducts, the ones inside the liver. It leads to their progressive inflammatory destruction. It has a very strong female predominance, about 9–1, and typically presents in women aged 40–50.
What's thought to cause it? Immune attack on the ducts?
Yes, the pathogenesis is likely T-cell mediated destruction of the bile duct epithelial cells. The trigger is unknown, probably some environmental factor in genetically susceptible individuals. Autoantibodies are prominent, especially anti-mitochondrial antibodies, AMAs, which are found in about 95% of patients and are highly specific for PBC.
AMAs are key for PBC.
Very key. Other autoantibodies like ANA or ASMA can also be present.
What does the liver look like microscopically in PBC? What's the hallmark?
The hallmark is inflammatory destruction of those small bile ducts within the portal tracts. The classic lesion is the florid duct lesion. You see a dense infiltrate of lymphocytes and plasma cells surrounding and invading the bile duct wall, causing damage to the epithelial cells. You often see granulomas in the portal tracts too, sometimes right next to the damaged duct.
And this damage is patchy.
Yes, initially it's patchy, affecting some portal tracts more than others. But over time, it leads to progressive loss of these small ducts, a condition called ductopenia.
And how does this show up clinically?
Early on, many patients are asymptomatic or have non-specific symptoms like fatigue. Pruritus, severe itching, is often an early and very bothersome symptom, likely due to retained bile salts. Hypercholesterolemia is common. As it progresses, you see jaundice, signs of portal hypertension like splenomegaly. It's often associated with other autoimmune diseases like Sjogren's syndrome or thyroid disease.
How's it treated?
It's slowly progressive. Ursodeoxycholic acid, UDCA, is the main medical therapy. It can slow progression and improve outcomes. But many patients eventually develop cirrhosis and liver failure, requiring a liver transplant. There's also an increased risk of hepatocellular carcinoma in patients with PBC cirrhosis.
Now, PSC, primary sclerosing cholangitis, how does that differ from PBC?
PSC is also a chronic inflammatory and fibrosing disease, but it affects both the intra and extrahepatic bile ducts, particularly the larger ones. This inflammation and scarring cause multiple strictures, narrowings, and dilations throughout the biliary tree.
Giving that beaded look on imaging.
Exactly, that characteristic beading appearance on cholangiography, which is the diagnostic gold standard for PSC.
And it's strongly linked to IBD, inflammatory bowel disease.
Yes, a very strong association, especially with ulcerative colitis, UC. About 70% of PSC patients also have UC, the fascinating gut-liver axis connection.
Pathogenesis, still unclear.
Still not fully understood. Autoimmune factors are suspected, maybe related to the IBD, possibly involving the gut microbiome or abnormal immune responses originating in the bowel that cross-react with bile duct antigens.
What are the key microscopic features in PSC?
In the affected large ducts, you see epithelial injury, often neutrophils early on, then chronic inflammation, leading to progressive fibrosis and stricture formation. A very characteristic finding, though not always present, is the onion skin fibrosis, concentric layers of fibrous tissue laid down around the shrinking duct lumen. Eventually, this can obliterate the duct, leaving just a fibrous scar, sometimes called a tombstone scar.
And the smaller ducts?
The smaller ducts often show features of cholestasis due to the upstream blockage, but they typically aren't directly inflamed like in PBC. The disease progresses over years to biliary cirrhosis.
And this also carries a significant cancer risk. Higher than PBC.
Yes, significantly higher. PSC is a major risk factor for cholangiocarcinoma, cancer of the bile ducts. The lifetime risk is estimated around 10–20%, which is much higher than in the general population or even other forms of cirrhosis.
How is PSC managed?
Clinically, it's usually a protracted course over 10–15 years, leading to cirrhosis and liver failure. Unfortunately, unlike PBC, there are no established medical therapies proven to stop the progression. Liver transplant is the main treatment for end-stage disease, and surveillance for cholangiocarcinoma is important.
Let's return to viral hepatitis for a deeper dive into the different viruses, A, B, C, D, and E.
Okay, the hepatotropic viruses, the ones that primarily target the liver?
Hepatitis A, HAV, is the relatively simpler one, right? Acute, self-limited.
Yes, compared to B and C, it's more straightforward. HAV is an RNA virus, transmitted fecal-oral, typically through contaminated food or water. It causes an acute hepatitis that is usually self-limited. People recover fully and clear the virus. Importantly, it never becomes chronic or leads to a carrier state.
So no long-term infection with Hep A?
Correct. Serology shows IgM anti-HAV during the acute infection, and then IgG anti-HBV appears, indicating past infection and lifelong immunity. The virus itself isn't thought to be directly toxic. The liver injury is primarily caused by the host's immune response, specifically cytotoxic T cells trying to eliminate infected hepatocytes.
Hepatitis B, HBV, is a whole different beast, much more complex.
It's far more complex, yes.
Yeah.
HBV is a DNA virus transmitted parenterally, blood, needles, sexually and perinatally, mother to child during birth. The outcome is highly variable.
What are the possibilities?
You can have acute hepatitis with full recovery and clearance, or acute liver failure, though that's less common, or it can progress to chronic hepatitis, which carries the long-term risks of cirrhosis and hepatocellular carcinoma, HCC. Or some people become inactive carriers, with the virus present but low replication and minimal liver damage.
And its life cycle is unusual.
Yes, for a DNA virus, it replicates via an RNA intermediate using reverse transcription, similar to retroviruses. A viral protein called HBX is thought to play a role in the development of HBV-associated HCC, possibly by interfering with host cell growth control.
HBV serology seems like a critical language to learn for this virus. It tells you everything.
It absolutely is the key to interpreting the infection stage, infectivity, and outcome. You need to know the main markers.
Okay, let's break them down. HBsAg.
HBsAg, the surface antigen. Its presence indicates ongoing infection, either acute or chronic. If it persists for more than 6 months, that defines chronic infection.
HBag.
HBag, the E's antigen, usually indicates active viral replication and high infectivity. Its loss, often followed by appearance of anti-HBV, generally signals lower replication.
HBV DNA.
HBV DNA is the direct measure of viral load, the amount of virus in the blood. Also indicates active replication and infectivity, used to monitor treatment response. Anti-HBs, the antibody to the surface antigen. Its presence indicates immunity, either from successful recovery from infection or from vaccination. This is the goal of vaccination.
Anti-HBC.
Anti-HBC, the antibody to the core antigen. Total anti-HBC indicates past or present infection. It persists for life. IgM anti-HBC specifically indicates acute infection, or sometimes a flare of chronic infection.
So for chronic infection, you'd typically see persistent HBsAg, maybe HBag, and HBV DNA, total anti-HBC, but no anti-HBs.
Exactly. That's the classic pattern. The immune system hasn't cleared the surface antigen.
Is there a vaccine for HBV?
Yes, a very effective recombinant vaccine exists and is part of routine childhood immunization in many countries. It generates protective anti-HBs.
And treatment for chronic HBV?
Yes. Antiviral treatments, mainly nucleotide analogs, can effectively suppress viral replication, lower HBV DNA, reduce liver inflammation and fibrosis progression, and decrease the risk of cirrhosis and HCC. However, achieving a complete cure, defined as loss of HBsAg, is still difficult with current therapies. Often requires long-term treatment.
And morphologically, anything characteristic for HBV on biopsy?
Yes, the ground glass hepatocyte is a classic finding in chronic HBV. These are swollen hepatocytes with abundant, pale, homogeneous cytoplasm, which represents accumulated HBsAg protein in the endoplasmic reticulum. You can confirm it with immunostaining for HBsAg.
Hepatitis C, HCV, is known for being the most common cause of chronic viral hepatitis, especially in the past.
That's right. HCV is an RNA virus, primarily transmitted parenterally, IV drug use being the most common route historically in the U.S. Also, blood transfusions before screening began around 1990.
And it usually doesn't cause symptoms initially.
Correct. Unlike HAV or HBV, acute HCV infection is rarely symptomatic. But the major issue is its high propensity for chronicity, About 80–90% of infected individuals fail to clear the virus and develop chronic infection.
Why is it so good at becoming chronic?
HCV is very adept at evading the host immune system. Its RNA polymerase lacks proofreading capability, so it mutates rapidly, creating a swarm of slightly different variants, or quasi-species, within a single host. This makes it hard for the immune system to target effectively. Plus, viral proteins actively interfere with the body's innate antiviral defenses, like the interferon signaling pathway.
Serology for HCV. How do you know if someone has it?
Initial screening is usually done by testing for anti-HCV antibodies. However, a positive antibody test doesn't distinguish between a past resolved infection and an ongoing active infection.
So how do you confirm active infection?
You need to test for HCV RNA, the viral genetic material itself. Persistent HCV RNA in the blood for more than 4 to 6 months defines chronic infection. This is also used to monitor treatment response.
But treatment for HCV has been revolutionary, right? Cures are possible.
Absolutely. One of the biggest medical breakthroughs in recent decades. Direct-acting antiviral agents, DAAs, have completely transformed treatment. These drugs specifically target key viral proteins essential for replication, like the protease, the NS5A protein, the polymerase.
So attacking the virus directly.
Exactly. Used in combination, these all-oral regimens offer extremely high cure rates. Cure is defined as sustained virologic response, SVR, undetectable HCV RNA, 12 weeks after finishing treatment. SVR rates are now routinely over 95%, often over 99%, even with short treatment durations of 8–12 weeks.
And this is a real cure.
Yes, because HCV is an RNA virus that doesn't integrate into the host genome, SVR is considered a true virologic cure. The main challenge now, as the source notes, is often access and the high cost of these medications, though prices have come down somewhat.
Any distinctive morphology for chronic HCV on biopsy?
Yes, a few features are characteristic, though not perfectly specific. Lymphoid aggregates, sometimes forming actual follicles within the portal tracts, are quite common. Steatosis, fatty change, is also frequently seen, particularly with genotype 3. Some bile duct injury can occur as well.
Okay, hepatitis D, HDV. This one needs HBV to survive.
It's a fascinating virus, a defective RNA virus. It requires the surface antigen protein, HBsAg, from HBV to assemble its own viral particles and infect new hepatocytes. So you can only get HDV infection if you already have HBV or if you get infected with both viruses simultaneously.
Transmission is similar to HBV.
Yes, primarily parenteral, through blood or needles. The clinical outcome depends heavily on the timing of the infections.
Co-infection versus superinfection, what's the difference?
A co-infection means you get infected with HBV and HDV at the same time. This typically causes an episode of acute hepatitis that might be more severe than HBV alone, but it's often self-limited, meaning both viruses are cleared. There's a higher risk of acute liver failure, though.
And superinfection.
Superinfection is when someone who is already a chronic HBV carrier gets infected with HDV later. This is usually much more serious. It often causes a severe flare of hepatitis, and in over 80% of cases, it leads to chronic HDV infection on top of the chronic HBV.
And that combination is bad news.
Very bad news. Chronic HBV-HDV co-infection leads to a much more rapid progression to cirrhosis and a significantly higher risk of developing HTC compared to chronic HBV alone.
Right.
It's the most severe form of chronic viral hepatitis.
So preventing HBV prevents HDV.
Exactly. Since HCV depends on HBV, the HBV vaccine effectively prevents HDV infection as well.
And finally, hepatitis E, HEV, another fecal oral one like Hep A.
Yes, HEV is an RNA virus transmitted enterically, often through contaminated water, particularly in developing countries. It also has zoonotic reservoirs, meaning it can spread from animals like pigs to humans.
How does it usually present?
It typically causes an acute, self-limited hepatitis, similar to HAV, in healthy individuals. However, it's particularly notorious for causing severe hepatitis and having a high fatality rate, around 20% when it occurs during pregnancy, especially in the third trimester. The reasons for this severity in pregnancy aren't fully understood.
Any chronic risk.
Unlike HEV, HEV can cause chronic hepatitis, but typically only in immunocompromised individuals, like organ transplant recipients. Like HAV, the virus is generally not thought to be directly cytopathic. The liver injury is primarily from the host immune response trying to clear it.
That's a great deep dive into the viruses. Let's move to autoimmune hepatitis, AIH. We mentioned it as a cause of acute failure, but it's also a chronic progressive disease, right?
Yes, AIH is a chronic and potentially progressive hepatitis caused by the body's own immune system mistakenly attacking liver cells, hepatocytes. It has a genetic predisposition, often linked to certain HLA types, and is characterized by the presence of specific autoantibodies and typically high levels of immunoglobulins, particularly IgG.
And it responds to immunosuppression.
Yes, that's a key feature. It generally responds well to treatment with corticosteroids and other immunosuppressive drugs like azathioprine. Like PBC, it's much more common in women, about 78% of cases.
How is it diagnosed? It sounds like it could mimic other things.
Diagnosis can be tricky. It usually involves a combination of clinical features, laboratory tests, checking for those autoantibodies, high IgG levels, liver enzymes, and characteristic findings on liver biopsy, while importantly excluding other causes like viral hepatitis, drug-induced injury, or metabolic diseases like Wilson's. Standardized scoring systems are often used to help establish the likelihood of AIH.
What are the key autoantibodies looked for?
AIH is classified into types based on autoantibody patterns. Type 1 is the most common form, especially in adults, and is associated with positive antinuclear antibodies, ANA, and or anti-smooth muscle antibodies, ASMA. Type 2 is less common, often seen in children and adolescents, and is characterized by antibodies to liver-kidney microsome type 1, anti-LKM1.
And the characteristic histology on biopsy, what do pathologists look for?
Liver biopsy shows inflammation and injury that can overlap with other forms of hepatitis, but certain features are suggestive of AIH. A key one is extensive interface hepatitis, where inflammation spills aggressively from the portal tracts into the adjacent liver lobule, attacking the hepatocytes right at the edge.
Okay, inflammation at the border.
Right. Another very characteristic feature is the presence of numerous plasma cells within the inflammatory infiltrate, often forming aggregates. You might also see lobular hepatitis, inflammation and cell death scattered within the lobule, emperipolesis, where lymphocytes seem to be inside hepatocytes, confluent necrosis, bridging different areas, and sometimes regenerative changes, like hepatocytes forming rosette patterns.
Does it always lead to cirrhosis?
If untreated, yes, it often progresses to fibrosis and cirrhosis. Some patients are actually diagnosed only when they present with complications of burnt-out cirrhosis, where the active inflammation has subsided, but the scarring is advanced.
Clinical presentation sounds variable too.
It really is. Some individuals are asymptomatic, detected only by incidentally found abnormal liver enzymes. Others present acutely, mimicking viral hepatitis or even fulminant acute liver failure. Many have a more insidious onset with symptoms like fatigue, malaise, jaundice, or joint pain. Without treatment, the disease is progressive in the majority and often leads to cirrhosis, liver failure, or death. But with prompt diagnosis and immunosuppressive therapy, the prognosis is generally good.
Shifting gears to a very common cause of liver injury, especially acute failure, drugs and toxins. The source flags acetaminophen as a major culprit in the U.S.
It is, absolutely. Drug and toxin-induced liver injury, often abbreviated DILI, is a huge issue. The liver is uniquely susceptible because it's the primary site for metabolizing most drugs and ingested chemicals.
That metabolism process can go wrong.
Yes. While metabolism usually makes substances less toxic and easier to excrete, sometimes the process, often involving the cytochrome P450 enzyme system concentrated in zone 3, can generate toxic intermediate metabolites that directly damage the liver cells.
So are all drug injuries the same? Predictable.
No, there are two main types based on mechanism. First is direct, or intrinsic, hepatotoxicity. This is predictable and dose-dependent. The more the substance you take, the more likely and severe the injury. Acetaminophen overdose is the classic example. Its toxic metabolite, NAPQI, causes zone 3 necrosis, especially if glutathione stores are depleted. This toxicity is predictably worse at higher doses and can be exacerbated by things that induce CYP450 enzymes, like chronic alcohol use.
Dose-dependent, predictable. What's the other type?
The other type is idiosyncratic hepatotoxicity. This is unpredictable, not clearly dose-dependent, can happen even at therapeutic doses, and affects only a small, susceptible minority of individuals exposed to the drug. The mechanisms are complex and varied, often involving immune reactions to drug-protein adducts or unusual metabolic pathways in susceptible people.
And this accounts for most DLI cases.
Yes, idiosyncratic reactions account for the majority of DLI cases, including reactions to many common prescription drugs, and, importantly, a growing number of herbal remedies and nutritional supplements, which people sometimes assume are harmless.
What does drug-induced injury look like on biopsy? Can you tell it's a drug?
It's often called the great mimicker because it can produce almost any pattern of liver injury seen in other diseases. It can be primarily hepatocellular, looking just like acute or chronic viral hepatitis or autoimmune hepatitis, often with centrosomal necrosis. It can be primarily cholestatic, mimicking bile duct obstruction, or it can be a mixed pattern.
So biopsy alone might not give the answer.
Not always, definitively. Direct toxins often cause necrosis with relatively little inflammation. Idiosyncratic reactions can have variable inflammation. Injury targeting the bile duct specifically can lead to cholestasis, ductular reactions, and sometimes chronic cholestasis or even loss of small bile ducts, vanishing bile duct syndrome.
How do you figure out if a drug caused the injury then?
Diagnosis relies heavily on taking a meticulous drug history and establishing a clear temporal relationship. Did the injury start shortly after a new drug was started, or the dose increased? Did it improve after stopping the suspected drug? The pattern of liver enzyme abnormalities, like the ratio of ALT to alkaline phosphatase, can also suggest hepatocellular versus cholestatic injury. Ruling out other causes is critical, but it can be very challenging.
And it can be serious.
Yes, DII is a major cause of acute liver failure, and the source highlights that about 10% of patients with severe DLI die or need a transplant, and a significant minority, maybe 17%, develop chronic liver disease.
Alcoholic liver disease is unfortunately a major problem, especially in Western countries.
It is a huge burden globally and particularly in the West. It represents a spectrum of injury, typically progressing through stages. First, fatty liver or steatosis, then alcoholic steatohepatitis, which involves inflammation and hepatocyte injury on top of the fat, and finally fibrosis, which can progress to cirrhosis.
Is it just about the amount of alcohol consumed? Drink enough and you get it.
Dose and duration are certainly major risk factors. There's a threshold effect. But notably, only a subset, maybe 10–20%, of chronic heavy drinkers develop severe alcoholic hepatitis or cirrhosis. This tells us other factors are critical in determining individual susceptibility.
Like what?
Gender plays a role. Women seem to be more susceptible to injury at lower doses and shorter durations of drinking than men. Ethnicity and genetics matter, like variants in alcohol metabolizing enzymes, such as the ALDH2 variant, common in East Asians, which affects acetaldehyde clearance. Comorbidities are also hugely important things like coexisting iron overload, having NFMD already, or chronic viral hepatitis, Hep B or C, act synergistically with alcohol to accelerate and worsen liver damage.
How does alcohol actually hurt the liver cells? What's the mechanism?
Several things happen. Alcohol metabolism itself, primarily by alcohol dehydrogenase and CYP2E1, generates NADH and reactive oxygen species, ROS. The altered redox state, high NADH and NAD+ ratio, promotes fatty acid synthesis and impairs their oxidation, leading to fat accumulation, steatosis.
Fat buildup.
The ROS cause oxidative stress, damaging cellular components and depleting protective antioxidants like glutathione. Acetaldehyde, the primary toxic metabolite of ethanol, forms adducts with proteins in DNA, impairing their function and triggering immune responses. These processes damage hepatocytes, induce inflammation, especially recruitment of neutrophils in alcoholic hepatitis, and activate hepatic stellate cells, the main drivers of fibrosis.
What do these stages look like in the liver under the microscope?
Steatosis is the earliest and most common finding, often reversible with abstinence. You see lipid droplets accumulating in hepatocytes, predominantly macrovesicular large droplets pushing the nucleus to the side. This typically starts in zone 3. The liver itself is often enlarged, yellow, and feels greasy.
And alcoholic hepatitis.
Alcoholic hepatitis, or steatohepatitis, represents a more severe acute-on-chronic inflammatory stage, often precipitated by binge drinking. The key features necessary for diagnosis are hepatocyte, ballooning, swollen, damaged hepatocytes.
Ballooning again.
Yes, essential for the diagnosis. These balloon cells often contain Mallory hyaline, those clumped intermediate filaments we mentioned earlier. You also see characteristic inflammatory infiltrate, typically rich in neutrophils, often clustering around the damaged hepatocytes. And crucially, a specific pattern of fibrosis starts to develop, often around the central veins, paravenular, and extending between individual hepatocytes in a chicken wire pattern. Necrosis of hepatocytes is also usually present.
Clinically, steatosis is often silent, but hepatitis is more acute and symptomatic.
Exactly. Steatosis is often asymptomatic or causes just mild discomfort or hepatomegaly. Alcoholic hepatitis typically presents more acutely, often after a period of heavy drinking, with malaise, anorexia, fever, jaundice, and hepatomegaly. A key lab finding, quite characteristic, is that the AST liver enzyme is usually significantly higher than the ALT, often with an AST ratio greater than 2. Cirrhosis develops more insidiously, often presenting late with complications of liver failure or portal hypertension.
And the long-term outlook with alcoholic liver disease depends on drinking.
Absolutely crucial. It's poor if the individual continues drinking heavily. The source gives some grim survival statistics for those who don't achieve abstinence. Causes of death and advanced disease include hepatic coma, massive bleeding from varices, infections, patients are often immunocompromised, hepatorenal syndrome, and the development of HCC, which is a known complication of alcoholic cirrhosis. Abstinence is the cornerstone of management and can significantly improve prognosis, especially if started before cirrhosis is advanced.
Non-alcoholic fatty liver disease, NAFLD, is incredibly common now. You said it's the leading chronic liver disease in the West, and morphologically sounds very similar to alcoholic liver disease.
The prevalence is staggering, affecting perhaps 25–30% of adults in developed countries, and it's rapidly increasing globally, even becoming a major issue in pediatrics. It's a spectrum, just like alcoholic disease.
What's the spectrum?
It ranges from simple fatty liver, just steatosis without significant inflammation or injury, often called NFL, to non-alcoholic steatohepatitis, or NASH. NASH is defined by the presence of steatosis, plus evidence of hepatocellular injury, like ballooning, and inflammation. NASH is the component that carries the significant risk of progressing to fibrosis, cirrhosis, HCC, and eventual liver failure or need for transplant.
And you mentioned cryptogenic cirrhosis might often be NASH.
Yes, it's now widely believed that a large proportion of cases previously labeled cryptogenic cirrhosis, means cirrhosis of unknown cause, are actually end-stage NASH, where the original hallmarks, the fat and inflammation, have burned out or become less prominent, leaving just the advanced fibrosis and cirrhosis.
The pathogenesis is strongly linked to insulin resistance and metabolic syndrome.
Yes, absolutely. NFLD is often considered the hepatic manifestation of the metabolic syndrome. Key factors driving it include insulin resistance, often associated with obesity and type 2 diabetes, which leads to increased fat storage in the liver. Dysfunctional adipose tissue releases more free fatty acids into the circulation. There's altered hepatic fatty acid metabolism, increased uptake, increased synthesis, decreased oxidation, impaired export as VLDL.
So fat metabolism is totally out of whack.
Right. Plus factors like decreased levels of the protective hormone adiponectin, increased pro-inflammatory cytokines like TNF-alpha coming from inflamed fat tissue, impaired cellular cleanup mechanisms like lipophagy within hepatocytes, potentially harmful substances coming from an altered gut microbiome like endotoxin, and dietary factors, especially high intake of fructose and trans fats, all contribute. Obstructive sleep apnea is also recognized as an independent risk factor. Injury seems to result from this metabolic stress combined with other hits.
And microscopically, why is it so hard to tell NASH and alcoholic hepatitis apart sometimes? They sound almost identical.
Because histologically, they share the core features required for diagnosis. NASH diagnosis requires steatosis, lobular inflammation, and hepatocyte, ballooning the same triad seen in alcoholic steatohepatitis. Biliary hyaline can be seen in NASH too, though perhaps less frequently.
Even the fibrosis pattern.
Yes, the pattern of fibrosis development is often very similar, typically starting in a parasinusoidal pattern in zone 3, giving that same chicken wire appearance on trichrome stain. Differentiating them based solely on biopsy findings can be extremely difficult, if not impossible, without clinical context, especially the history of alcohol consumption. As mentioned in established cirrhosis, the steatosis and ballooning may actually decrease or disappear, making it histologically indistinguishable from other causes of cirrhosis.
How is NASH managed? Is it reversible?
The cornerstone of management is addressing the underlying metabolic risk factors. Lifestyle modification is key. Weight loss through diet and exercise is the most effective proven therapy. Significant weight loss, around 7–10% of body weight, can improve or even reverse steatosis, inflammation, ballooning, and sometimes even fibrosis. Managing associated conditions like diabetes, hypertension, and dyslipidemia is also crucial. Pharmacologic treatments specifically targeting NASH pathways are a major area of research, with several agents in late-stage clinical trials, but none are FDA approved specifically for NASH fibrosis yet.
Let's dive into some important hereditary liver diseases. First, hemochromatosis. Sounds like iron overload.
Exactly. Hereditary hemochromatosis HH is a genetic disorder leading to excessive absorption of dietary iron and its progressive accumulation in various organs, causing tissue damage and organ dysfunction over time.
Which organs are most affected?
The primary targets are the liver, where it classically causes fibrosis and cirrhosis, the heart, leading to cardiomyopathy and heart failure, the pancreas, causing diabetes mellitus due to damage to islet cells, the skin, resulting in a characteristic bronze or slate gray pigmentation, the joints, causing arthropathy, and endocrine glands like the pituitary and testes.
What's the genetic cause? How does the iron build up?
The vast majority of cases, especially in people of Northern European descent, are caused by mutations in the HFE gene, most commonly the C282Y mutation, often homozygous, 2 copies. The HFE protein plays a role in regulating hepcidin, the master hormone controlling iron balance. Mutations lead to inappropriately low hepcidin levels.
Low hepcidin means.
Low hepcidin essentially signals the body to absorb more iron from the gut and release more iron from storage sites, even when body iron stores are already high. So iron steadily accumulates over decades. It's one of those common genetic disorders, with about 1 in 220 people of Northern European ancestry being C282Y homozygotes. However, importantly, it has relatively low clinical penetrance, meaning many people with the genotype never develop severe iron overload or clinical disease. Other factors likely modify the risk.
What does iron overload look like in the liver? How do you see it?
On biopsy, the hallmark is the deposition of hemosiderin, the storage form of iron, within cells. It initially accumulates predominantly in periportal hepatocytes, zone 1, and Kupffer cells, then spreads throughout the lobule and into bile duct epithelium as overload becomes severe. Hemosiderin granules stain bright blue with the Prussian blue iron stain, making it easy to visualize.
And the iron itself causes damage.
Yes, iron is directly toxic, particularly through generating reactive oxygen species via the Fenton reaction. This causes oxidative damage to lipids, proteins, and DNA. It also activates hepatic stellate cells, stimulating collagen production and leading to fibrosis, which progresses over time to micronodular cirrhosis if untreated. The liver becomes enlarged, firm, and can appear dark brown or black grossly.
And in other organs, pancreas, heart.
Iron deposition in the pancreatic islets destroys beta cells, causing diabetes. Bronze diabetes if skin pigmentation is also present. In the heart muscle, it causes cardiomyopathy, arrhythmias, and heart failure. In the skin, increased melanin production combined with hemosiderin deposition causes the pigmentation. In the joints, iron deposition and associated calcium pyrophosphate deposition disease cause arthritis, particularly in the hands, MCP joints. It can also cause pituitary dysfunction leading to hypogonadism and testicular atrophy.
How is it diagnosed and treated? Can you get the iron out?
Diagnosis usually starts with screening iron, studies serum iron, transferrin saturation, usually high, and serum ferritin, reflects iron stores, usually very high. Genetic testing for HFE mutations confirms the diagnosis in most cases. Liver biopsy might be done to assess the degree of iron overload and stage the fibrosis cirrhosis, especially if ferritin is very high or liver enzymes are abnormal. The treatment is remarkably simple and effective if started before irreversible organ damage occurs. Therapeutic phlebotomy.
Just removing blood?
Yes, regularly removing units of blood effectively depletes the excess iron stores over time. Once stores are normalized, periodic maintenance phlebotomy keeps them down. It's very effective at preventing complications if started early.
Wilson disease is another metal overload issue, but with copper this time.
Yes, Wilson disease is an autosomal recessive disorder caused by mutations in the ATP7B gene. This gene codes for a copper-transporting ATPase protein located mainly in hepatocytes. This protein has 2 key jobs: excreting excess copper into the bile and incorporating copper into ceruloplasmin, the main copper-carrying protein in the blood.
So if ATP7B doesn't work,
If ATP7B is defective, copper excretion into bile is impaired, and copper doesn't get incorporated properly into ceruloplasmin, leading to low blood ceruloplasmin levels. As a result, copper progressively accumulates, first in the liver. When the liver's storage capacity is overwhelmed, copper spills into the bloodstream and deposits in other tissues, particularly the brain, especially the basal ganglia, the eyes, cornea, kidneys, and red blood cells.
how does Wilson disease present? It sounds like it could affect many systems.
It's known for having highly variable presentations and age of onset, typically between ages 6 and 40, but the average is around 11 years. Liver disease is the most common initial presentation, especially in children and adolescents. This can range from asymptomatic enzyme elevations to acute hepatitis mimicking viral hepatitis, sometimes with associated hemolytic anemia, to chronic active hepatitis, or even fulminant liver failure. Cirrhosis develops eventually if untreated.
And neurological symptoms.
Neurologic or psychiatric symptoms are more common presentations in young adults. These result from copper deposition in the brain and can include movement disorders, tremor, Parkinsonism-like features, dystonia, dysarthria, coordination problems, and psychiatric disturbances, depression, personality changes, psychosis. A classic physical sign is Kaiser-Fleischer rings greenish-brown copper deposits into Descemet's membrane of the cornea, best seen on slit lamp examination. Hemolytic anemia can also occur due to copper toxicity to red cells.
Diagnosis. How do you confirm it?
Diagnosis usually relies on a combination of findings. Low serum ceruloplasmin levels are characteristic, found in 90%, though normal levels don't exclude it. Elevated 24-hour urinary copper excretion, especially after stimulation with D-penicillamine, is key. Measuring copper concentration in the liver biopsy sample remains a gold standard if needed levels are usually markedly elevated. Characteristic morphologic findings on liver biopsy, like steatosis, glycogenated nuclei, Mallory-Hyaline, specific mitochondrial changes, can be suggestive. Genetic testing for ATP7D mutations can confirm the diagnosis.
And treatment. Can you get rid of the copper?
Yes, treatment aims to remove excess accumulated copper and prevent further buildup. Lifelong therapy is required. Copper chelating agents, like D-penicillamine or trientine, bind copper and increase its excretion in the urine. Zinc therapy, usually zinc acetate, works differently. It blocks copper absorption from the gut by inducing metallothionein in intestinal cells. Diet low in copper might help. Liver transplantation is curative, as it provides a liver with functional ATP7B, and it's indicated for patients presenting with fulminant liver failure or decompensated cirrhosis unresponsive to medical therapy.
Alpha-1 antitrypsin deficiency. This one seems counterintuitive for liver disease, as it's mainly known for causing lung problems like emphysema.
It's a fascinating example of how a single gene defect can cause disease through two different mechanisms: loss of function in the lungs and toxic gain of function in the liver. It's an autosomal recessive disorder caused by mutations in the SERPINA1 gene, which codes for alpha-1 antitrypsin, A101T, a protease inhibitor primarily made in the liver.
So the lung problem is from lack of the inhibitor.
Exactly. A1AT's main job is to protect tissues, especially the lungs, from damage by neutrophil elastase, an enzyme released during inflammation. Low levels of A1AT in the blood lead to unchecked elastase activity in the lungs, progressively destroying alveolar walls and causing emphysema, especially in smokers.
So how does that same deficiency cause liver disease? It's not lack of A1AT in the liver, is it?
No, the liver disease mechanism is completely different and relates to the mutant protein itself. The most common severe deficiency variant is called PyZ. The mutation causes the A1AT protein to misfold as is being synthesized in the hepatocyte's endoplasmic reticulum, ER. This misfolded protein can't be secreted properly into the blood, hence the low serum levels. But more importantly, it tends to aggregate and accumulate within the ER of the hepatocytes.
So the liver cells get clogged up with bad protein.
Essentially, yes. These intracellular aggregates trigger a state of chronic ER stress, activate inflammatory pathways like NF-key, and increase the susceptibility of the hepatocyte to apoptosis, programmed cell death. So the liver disease is caused by this toxic gain of function, the accumulation of the abnormal PyZ protein within the liver cells themselves.
The PyZ genotype is the most common severe form.
Yes, individuals homozygous for the Z allele, PyZ genotype, have very low serum levels, about 10-15% of normal, and are at high risk for both emphysema and liver disease. It's particularly common in people of Northern European descent, about 1 in 1,800 live births. However, the risk and severity of liver disease in PyZ individuals is quite variable. Only a minority, perhaps 10-20%, develop clinically significant liver disease during their lifetime. Other genetic or environmental factors likely modify this risk.
What does that look like microscopically? How do you spot it?
The diagnostic hallmark on liver biopsy is the presence of distinctive round to oval cytoplasmic globular inclusions within hepatocytes. These globules are composed of the aggregated, misfolded PZ protein stuck in the ER. They stain bright pink or magenta with the PAS stain and are resistant to digestion by diastase, PASD positive, which helps distinguish them from glycogen. Electron microscopy confirms they are within dilated ER cisternae.
How does the liver disease present clinically?
It can present at various ages. Some PyZ infants present with neonatal cholestasis or hepatitis. Others develop liver disease later in childhood or adulthood, manifesting as chronic hepatitis or cirrhosis. Importantly, PZZ individuals have a significantly increased risk of developing hepatocellular carcinoma, about 2-3% lifetime risk. And this can occur even without pre-existing cirrhosis, suggesting the protein accumulation itself might be carcinogenic.
And treatment? Transplant again.
There's no specific treatment to prevent the protein accumulation currently. Management focuses on monitoring liver health and managing complications. Liver transplantation is an option for those who develop end-stage liver disease. Transplant is curative for the liver disease, as the new liver produces normal ion-1AT. However, it doesn't correct the deficiency in the rest of the body, so the risk of emphysema remains unless lung transplant is also considered.
Let's look at conditions where the liver is impacted by problems with blood flow getting blood in, through, or out. The source breaks this down nicely.
Yes, thinking about the circulation is crucial. Disruptions at different points cause distinct patterns of liver injury.
Okay, impaired inflow first. Problems getting blood to the liver.
This means issues with either the hepatic artery or the portal vein. Hepatic artery compromise, like thrombosis or ligation, rarely causes a significant liver infarct on its own because the portal vein still provides blood flow and oxygen. You usually only see an infarct if the portal supply is also compromised or if the patient is in shock. Portal vein obstruction or thrombosis is more common.
And that causes.
It mainly causes portal hypertension before the liver, prehepatic, leading to complications like varices and splenomegaly, but usually doesn't cause direct damage to the liver parenchyma itself unless it's very acute or extensive.
What about obstruction of smaller portal vein branches within the liver? Can that happen?
Yes. The most common cause globally is schistosomiasis, where the parasite eggs get lodged in small portal venules within the portal tracts, causing inflammation, granulomas, and fibrosis that obstructs flow, pipe stem fibrosis. Other causes fall under the umbrella of idiopathic non-cirrhotic portal hypertension, or related syndromes. These involve obstruction or obliteration of small portal veins or venules due to various causes like hypercoagulable states, infections, HIV, certain drugs or toxins, autoimmune conditions, or sometimes it's truly idiopathic. The prevalence varies geographically. It causes portal hypertension without the diffuse fibrosis of cirrhosis.
Okay, now impaired flow through the liver sinusoids, the tiny vessels inside.
Right, problems within the liver parenchyma itself obstructing flow. Examples include sickled red blood cells physically clogging the sinusoids during a sickle cell crisis. Disseminated intravascular coagulation, DIC, can cause fibrin thrombi in the sinusoids. Eclampsia can be associated with sinusoidal fibrin deposition and obstruction. Ileosis hepatis involves unexplained dilation of sinusoids forming blood-filled cavities.
And sinusoidal obstruction syndrome, SOS, that sounds specific.
Yes, SOS, which used to be called veno-occlusive disease, VOD, is a significant condition, often seen after hematopoietic stem cell transplantation or exposure to certain chemotherapies or toxins, like pyrrolizidine alkaloids from some plants. It involves toxic injury primarily to the endothelial cells lining the sinusoids and small terminal hepatic venules. This leads to sloughing of these cells, obstruction of the sinusoids and venules by debris and fibrin, causing congestion, necrosis, and impaired outflow at the sinusoidal level. Severe SOS has a very high mortality rate.
And finally, impaired outflow blocking blood from leaving the liver.
The main condition here is obstruction of the large hepatic veins or the intrahepatic or suprahepatic inferior vena cava, IVC. This is known as Budd-Chiari syndrome. It prevents blood from draining properly from the liver.
What causes Budd-Chiari?
It's usually caused by thrombosis, blood clots forming in these veins. Underlying causes are often myeloproliferative neoplasms, like polycythemia vera, inherited or acquired hypercoagulable states, like factor V Leiden, protein CS deficiency, antiphospholipid syndrome, conditions associated with thrombosis, like oral contraceptive use or pregnancy, paroxysmal nocturnal hemoglobinuria, PNH, or sometimes tumors compressing or invading the veins.
And what does this blockage do to the liver?
The lack of outflow leads to severe sinusoidal congestion, hemorrhagic necrosis, particularly around these central veins, zone 3, and rapid development of hepatomegaly, ascites, and abdominal pain. It's often a medical emergency.
And heart failure can also cause liver congestion, but more passively.
Yes. Specifically, right-sided heart failure causes blood to back up systemically, increasing pressure in the IVC and hepatic veins. This leads to passive congestion of the liver. Grossly, this can give the liver a characteristic mottled appearance known as nutmeg liver, because the congested reddish central areas contrast with the paler, sometimes fatty, surrounding parenchyma.
Nutmeg liver. Okay.
Microscopically, you see dilation and congestion of the central veins and adjacent sinusoids, often with atrophy or necrosis of the central lobular hepatocytes due to hypoxia. If the congestion is severe and chronic, it can eventually lead to fibrosis centered around the central veins, sometimes progressing to cardiac cirrhosis, though true cirrhosis from heart failure is less common than from other causes.
Let's briefly touch on liver diseases specifically associated with pregnancy. It's a unique physiological state.
Yes, pregnancy can unmask or cause specific liver issues. While common viral hepatitis, like HIV, HBV, HCV, usually behave similarly in pregnant versus non-pregnant women, hepatitis E, as we noted, is notably more severe during pregnancy with a significantly higher mortality risk, around 20%. Rare infections like herpes simplex virus, HSV, or listeria can also cause severe liver dysfunction in pregnancy.
Acute fatty liver of pregnancy, AFLP, sounds very serious.
It is. AFLP is a rare but potentially devastating condition occurring late in pregnancy, usually the third trimester. It causes acute liver failure with symptoms like nausea, vomiting, jaundice, encephalopathy, and coagulopathy. It can be fatal to both mother and fetus if not recognized and managed quickly.
What causes it? Is it related to an AFLD?
Not directly related to typical NFLD. A fascinating aspect of its pathogenesis is that in many cases, it's linked to an underlying inherited metabolic disorder in the fetus, specifically a defect in mitochondrial long-chain fatty acid oxidation enzymes, like LCH deficiency. Toxic fatty acid metabolites produced by the fetus accumulate and cross the placenta, overwhelming the mother's metabolic capacity and causing liver injury.
Wow, the fetus's metabolism affects the mother's liver.
Yes, in these specific genetic interactions. Morphologically, the mother's liver shows diffuse microvesicular steatosis, those tiny fat droplets within hepatocytes, rather than the macrovesicular fat of typical NFLD. Clinically, it often presents with symptoms that can overlap with severe preeclampsia or HELLP syndrome. Prompt delivery of the baby is the cornerstone of treatment and is usually curative for the mother.
And intrahepatic cholestasis of pregnancy, ICP. That sounds less severe.
ICP is generally less severe than AFLP, but can be very distressing for the mother due to intense pruritus, itching, especially on the palms and soles, typically starting in the second or third trimester. Jaundice can occur, but is less common. It resolves completely after delivery.
What causes the itching?
It's thought to be due to impaired bile acid transport and excretion by the liver, leading to high levels of bile salts accumulating in the mother's bloodstream and depositing in the skin. The exact cause involves a combination of genetic predisposition, mutations in genes coding for bile salt transporters like ABCB4 or ABCB11, the high hormonal milieu of pregnancy, estrogen and progesterone metabolites can impair bile flow, and possibly environmental factors. While generally benign for the mother after delivery, ICP is associated with a modestly increased risk of adverse fetal outcomes, like preterm birth or stillbirth, and it tends to recur in subsequent pregnancies.
Okay, let's move to liver tumors. The source makes a crucial point right at the start. Metastatic cancer hitting the liver is far, far more common than primary liver cancer starting there.
Absolutely, that's a key perspective. The liver's large size and rich dual blood supply make it a very frequent site for metastases to land and grow. The most common primary sites that spread to the liver are colon, breast, lung, and pancreas, but many others can too. Metastases usually appear as multiple nodules scattered throughout the liver and often cause striking liver enlargement, hepatomegaly, sometimes even before liver function tests become significantly abnormal.
What about tumors that start in the liver? Let's cover the benign ones first. Are they common?
The most common benign liver tumor overall is the cavernous hemangioma. It's basically a tangle of blood vessels, like a birthmark inside the liver. They are extremely common, often found incidentally on imaging done for other reasons, and almost always harmless, rarely requiring treatment.
Okay, hemangiomas are common and benign. What about hepatocellular adenomas?
Hepatocellular adenomas are benign tumors composed of hepatocytes. They are much less common than hemangiomas, but clinically more significant. They are strongly associated with exposure to estrogens, particularly long-term oral contraceptive use in women, and also with anabolic steroid use.
Why are they clinically significant if they're benign?
Two main reasons. Risk of hemorrhage, they can rupture and bleed, sometimes massively into the abdomen, and a risk of malignant transformation into hepatocellular carcinoma, HCC. This risk varies depending on the subtype of adenoma.
The material mentions classifying adenomas by driver mutations. Why is that important? Helps predict risk.
Exactly. This molecular subclassification is now standard because it helps stratify the risk. The main subtypes are 1. HNF1 inactivated adenomas, often associated with MODY3 diabetes, typically show diffuse fatty change microscopically, lack expression of a protein called LFABP, and have a very low risk of malignant transformation. 2. BECET inactivated adenomas. These carry the highest risk of transformation to HTC. They show nuclear staining for BECET on immunohistochemistry. 3. Inflammatory adenomas, often associated with metabolic syndrome or NAFLD, frequently have mutations activating the GP130 signaling pathway, show inflammatory infiltrates, sinusoidal dilation, and stain positive for inflammatory markers like serum amyloid A or C-reactive protein, CRP. They have a low but definite risk of malignancy. 3. Inflammatory adenomas. 4. Unclassified adenomas.
So knowing the subtype is key for management. What do they look like?
Grossly, they are typically solitary, well demarcated, often pale or yellowish masses. Microscopically, they consist of sheets or cords of relatively normal-looking hepatocytes, often slightly larger than normal, arranged in thin plates. They have prominent arteries, but a key distinguishing feature is the absence of normal portal tracts and bile ducts within the lesion.
Focal nodular hyperplasia, FNH, is also benign but sounds different, not considered a true tumor.
Right, FNH is generally considered a non-neoplastic, hyperplastic regenerative response of hepatocytes to localized alterations in blood flow, perhaps related to a vascular anomaly. It's quite common, second only to hemangiomas among benign lesions.
Does it have a characteristic look?
Yes, very characteristic in many cases. About 80% have a distinctive central stellate scar composed of fibrous tissue, which often contains large, thick-walled, abnormal blood vessels and sometimes proliferating bile ductules. Fibrous septa radiate outwards from this scar, dividing the lesion into nodules. Like adenomas, FNH lesions lack normal portal tracts. A Dane called glutamine synthetase, GS, often shows a characteristic map-like pattern of staining. FNH is considered entirely benign with essentially no risk of hemorrhage or malignant transformation, so it usually doesn't require treatment unless it's very large and causing symptoms.
Any other benign or non-neoplastic mass lesions we should know? Things that look like tumors but aren't.
Yes, definitely. Liver abscesses, bacterial or amoebic. Granulomas from infections like TB or sarcoidosis, or rare inflammatory pseudotumors can present as mass lesions. Also, regenerative nodules can form in response to localized injury or altered blood flow, like in Biliary syndrome or adjacent to large hemangiomas. Nodular regenerative hyperplasia, NRH, is a distinct condition where the entire liver develops small regenerative nodules without the extensive bridging fibrosis of cirrhosis. It can mimic cirrhosis clinically by causing non-cirrhotic portal hypertension.
And benign tumors originating from the bile ducts, are they common?
Bile duct adenomas and biliary hemochromatosis, also known as von Meyenberg complexes, are the main ones. Both are usually small, incidental findings discovered at autopsy or on imaging. Bile duct adenomas are now considered true benign neoplasms, sometimes harboring BRAF mutations. Biliary hemochromatosis are thought to be developmental malformations, remnants of the embryonic ductal plate, appearing as small clusters of haphazardly arranged, often dilated, small bile ducts embedded in fibrous stroma near portal tracts. Both are benign.
Okay, now for the big one. Primary malignant liver cancer. Hepatocellular carcinoma, HCC. This is the most common primary.
Yes, HCC is by far the most common primary malignancy of the liver worldwide. And the overwhelming majority of cases, probably 80–90%, arise in the setting of established chronic liver disease and cirrhosis.
So cirrhosis is the biggest risk factor.
Absolutely. Any cause of chronic liver injury leading to cirrhosis significantly increases the risk. The major drivers globally are chronic hepatitis B, even without cirrhosis sometimes, chronic hepatitis C, alcoholic liver disease, and increasingly NAFLD. Other causes of cirrhosis like hemochromatosis and alpha-1 antitrypsin deficiency also carry a high risk. The thinking is that the chronic cycle of injury, inflammation, and regeneration in cirrhosis drives the accumulation of genetic mutations in hepatocytes, eventually leading to cancer.
Any other major risk factors besides cirrhosis?
Aflatoxin exposure is a big one, particularly in parts of Asia and Africa. Aflatoxin is a mycotoxin produced by Aspergillus molds that can contaminate improperly stored grains and nuts. It's a potent liver carcinogen and acts synergistically with chronic HBV infection, dramatically increasing HCC risk.
Does HCC develop from pre-malignant lesions, like polyps in the colon?
Yes. In the context of cirrhosis, there's often a stepwise progression recognized. It starts with regenerative nodules, which can then develop into low-grade dysplastic nodules, then high-grade dysplastic nodules, which have a high risk of progressing to early HCC. Sometimes you can even see a nodule-in-nodule appearance on imaging or pathology, where a focus of HCC is visibly arising within a pre-existing dysplastic nodule.
What does HCC look like grossly and microscopically?
Grossly, it can present in several patterns. As a single large mass, as multiple distinct nodules scattered throughout the liver, or as a diffuse infiltrative growth pattern that blends into the surrounding cirrhotic liver, making it hard to delineate. It's often softer and more variegated in color, yellowish, greenish, if producing bile, hemorrhagic, than the surrounding liver tissue.
And under the microscope?
Microscopically, HCC is composed of malignant cells that resemble hepatocytes, but they show varying degrees of atypia, abnormal nuclei, increased size, etc., and abnormal architecture. The most classic pattern is growth in thickened trabeculae plates of tumor cells that are more than 2 or 3 cells thick, which is abnormal. Other patterns include solid sheets, pseudoglandular structures, trying to form lumens, or serous with dense fibrosis. A key diagnostic feature distinguishing HCC from benign nodules is the presence of unpaired atypical arteries within the tumor stroma and the absence of normal portal tracts and bile ducts within the tumor itself.
Is there a specific variant mentioned?
Yes, fibrolamellar carcinoma is a distinct variant. It typically occurs in younger adults, under 40, without underlying chronic liver disease or cirrhosis. It has characteristic histology with large eosinophilic tumor cells arranged in cords separated by dense lamellar fibrous bands. It generally has a better prognosis than conventional HCC arising in cirrhosis.
How is HCC usually detected? Are there symptoms?
Unfortunately, early HCC often causes no specific symptoms beyond those of the underlying cirrhosis. Symptoms like worsening abdominal pain, weight loss, palpable mass, or sudden decompensation of previously stable cirrhosis should raise suspicion. Screening with abdominal ultrasound, usually around 6 months, is recommended for all patients with cirrhosis and some high-risk chronic HBV carriers to detect tumors at an earlier, potentially curable stage.
What about tumor markers like AFP?
Alpha-fetoprotein AFP levels can be elevated, especially in advanced HCC, but it's not sensitive or specific enough for reliable screening or diagnosis on its own. Many small HCCs have normal AFP. Diagnosis relies heavily on characteristic imaging findings with contrast-enhanced CT or MRI. HCC typically shows intense arterial enhancement in the early phase, followed by rapid washout of contrast in the later venous or delayed phases. This pattern is often considered diagnostic in high-risk patients, sometimes avoiding the need for biopsy.
Prognosis. Generally not good.
Prognosis is generally poor overall, unfortunately. This is partly due to the often advanced stage at diagnosis, the frequent presence of underlying liver dysfunction from cirrhosis, limiting treatment options, and the tumor's relative resistance to conventional chemotherapy. Prognosis is much better if the tumor is detected early when potentially curative treatments like surgical resection, liver transplantation, or local ablation are feasible. But recurrence rates are high even after curative intent therapy.
Okay, what about malignant tumors arising from the bile ducts cholangiocarcinoma? Less common than HCC.
Yes, much less common than HCC, but still significant. Cholangiocarcinoma is cancer arising from the epithelial cells lining the bile ducts, cholangiocytes. It can occur anywhere along the biliary tree, from the smallest intrahepatic ductules up to the extrahepatic bile ducts near the pancreas.
Intrahepatic versus extrahepatic.
Right. Intrahepatic cholangiocarcinoma arises from ducts within the liver parenchyma itself. Extrahepatic cholangiocarcinoma arises from the ducts outside the liver, including the common hepatic duct and common bile duct. A specific type of extrahepatic tumor occurring at the confluence of the left and right hepatic ducts is called a Klatskin tumor.
What are the risk factors? Is it also linked to chronic injury?
Yes, chronic inflammation and injury of the biliary epithelium seem to be the major drivers. Key risk factors include primary sclerosing cholangitis, BSC, which carries a very high risk, congenital biliary abnormalities like choledochal cysts or Caroli's disease, chronic infection with liver flukes, Opus thorcus viverini, Clonorchis sinensis, which are common parasites in parts of Southeast Asia and induce chronic inflammation. Intrahepatic gallstones, hepatolithiasis, are also a risk factor. Exposure to certain toxins like thorotrast. Unlike HCC, cirrhosis is not a major risk factor for most cholangiocarcinomas, although some can arise in cirrhotic livers. Genetic mutations in pathways involving EGF receptors, RAS, and TP53 are often found.
Morphology. Does it look different from HCC?
Yes, quite different. Intrahepatic cholangiocarcinomas often present as firm, white, solid masses, frequently in a non-cirrhotic liver. Extrahepatic tumors are often small when diagnosed because they tend to cause biliary obstruction and jaundice early. Microscopically, the vast majority are adenocarcinomas, meaning they form glandular or tubular structures resembling other adenocarcinomas like pancreatic or colon cancer. These malignant glands are typically embedded in a dense fibrous desmoplastic stroma, which contributes to their firm consistency.
Any other key features?
They have a strong tendency for invasion into surrounding structures, including lymphovascular spaces and perineural invasion, tracking along nerves, which are common findings and contribute to their poor prognosis and high recurrence rates. They are thought to arise from precursor lesions called biliary intraepithelial neoplasia, BILN, similar to dysplasia in other organs.
Prognosis? Also poor.
Yes, generally poor overall prognosis. They're often diagnosed at a relatively advanced stage, especially intrahepatic ones, which may not cause symptoms until late. Symptoms when they occur, like jaundice, pain, weight loss, are often nonspecific unless related to biliary obstruction. Surgical resection offers the only chance for cure, but is only possible in a minority of patients, and recurrence rates are high. They're also relatively resistant to chemotherapy and radiation.
Are there any other primary hepatic malignancies mentioned in the material? Less common ones?
Yes, the source briefly notes a few others. Combined hepatocellular cholangiocarcinoma, tumors showing features of both HCC and cholangiocarcinoma. Angiosarcoma, a rare malignant tumor of blood vessel lining cells, historically associated with specific toxic exposures like vinyl chloride, arsenic, or thorotrast, an old contrast agent. Epithelioid hemangioendothelioma, another rare vascular tumor considered of intermediate malignant potential. And very rarely, primary hepatic lymphomas, usually B-cell type, can occur.
Okay, we've covered the liver in incredible depth. Now, let's shift to its close partner, the gallbladder, and its associated diseases. What are the main issues there?
Diseases of the gallbladder are very common, and they are strongly linked to the presence of gallstones, cholelithiasis. The main problems are gallstones themselves, inflammation of the gallbladder, cholecystitis, and gallbladder cancer. The epidemiology of cholecystitis and gallbladder cancer often mirrors the prevalence of gallstones in a given population.
So, gallstones or cholelithiasis are central. What are the main types? You mentioned cholesterol and pigment stones earlier.
Right, those are the two major classes. Cholesterol stones are the most common type by far in Western countries, accounting for maybe 80–90% of stones. They're composed primarily of cholesterol monohydrate, at least 50%, often much more. They're typically oval, often large, yellow-greenish in color, and usually radiolucent on standard X-rays unless they become secondarily calcified.
And pigment stones.
Pigment stones are made mainly of bilirubin calcium salts. They're generally smaller, darker, black or brown, and more common in non-Western populations, particularly in Asia. They're often associated with conditions that increase unconjugated bilirubin in bile, like chronic hemolytic anemias, for example, sickle cell disease, or biliary infections. Black pigment stones are typically hard and found in sterile bile, while brown pigment stones are softer, more clay-like, and often associated with bacterial infection in the bile ducts. Pigment stones, due to their calcium content, are more likely to be radiopaque on X-ray than pure cholesterol stones.
What puts someone at risk for developing cholesterol gallstones? The source lists many risk factors. The 4Fs often come up.
Yes, the classic mnemonic female, fat, 40, fertile captures some key risks, though it's a bit simplistic. Female gender is a major risk factor. Estrogens increase cholesterol secretion into bile, and they decrease gallbladder motility. Increasing age is also a risk. Obesity is strongly associated. Rapid weight loss, like after bariatric surgery, paradoxically increases risk temporarily due to cholesterol mobilization. Gallbladder stasis or hypomotility from pregnancy, prolonged fasting, spinal cord injury allows bile to sit longer, promoting stone formation. Hereditary factors involving genes that control cholesterol transport into bile, like variants in the ABCG5G8 transporters, also play a significant role. Certain ethnic groups, like Native Americans, have very high rates.
And risk factors for pigment stones, are they different?
Yes, largely different. The main risk factors relate to increased unconjugated bilirubin in bile. So, chronic hemolytic conditions, like sickle cell anemia, hereditary circulatory, thalassemia, are major risks for black pigment stones. Biliary tract infections, especially with bacteria that produce beta-glucuronidases, which deconjugate bilirubin, or parasites like Ascaris or liver flukes, are strongly associated with brown pigment stones, particularly in Asian populations. Conditions affecting the terminal ileum, like Crohn's disease or surgical resection, impair bile salt reabsorption, altering bile composition and increasing risk. Geographic location, more common in Asia, and socioeconomic factors also play a role.
How exactly do cholesterol stones form? What needs to go wrong in the bile?
Cholesterol is normally kept dissolved in bile within micelles formed by bile salts and phospholipids, mainly lecithin. Stone formation requires several things to happen, usually concurrently. 1. Supersaturation. The liver secretes bile that contains more cholesterol than can be kept dissolved by the available bile salts and lecithin. 2. Hypomotility stasis. Gallbladder doesn't empty effectively or frequently enough, allowing bile to sit and concentrate. 3. Nucleation. Cholesterol crystals start to precipitate out of the supersaturated bile. This requires a nidus or promoter for crystallization. 4. Mucus trapping accretion. Excessive mucus secretion by the gallbladder traps the microscopic crystals, allowing them to aggregate and grow into macroscopic stones.
And pigment stones, how do they form?
Their formation is driven by the precipitation of insoluble calcium salts of unconjugated bilirubin. This happens when there are high concentrations of unconjugated bilirubin in bile, either due to increased production, like in hemolysis, or due to bacterial beta-glucuronidase activity converting soluble conjugated bilirubin back into insoluble unconjugated bilirubin within the biliary tract. This unconjugated bilirubin then combines with calcium to form the stones.
Clinically, are gallstones always symptomatic? Do people know they have them?
No, actually, the majority of people with gallstones, maybe 70–80%, are completely asymptomatic throughout their lives. The stones are often found incidentally. Symptoms typically occur only when a stone obstructs bile flow, usually from the gallbladder, cystic duct, or sometimes in the common bile duct.
What's the most common symptom when they do cause problems?
The most characteristic symptom is biliary colic. This is typically a severe, steady pain in the right upper quadrant of the abdomen or the epigastrium, often radiating to the right shoulder or back. It usually starts suddenly, can last from 30 minutes to several hours, and then subsides. It's often triggered by eating a fatty meal, which stimulates gallbladder contraction against an obstructed outlet.
What are the more serious complications of gallstones, beyond just pain?
The pain of colic is bad enough, but more serious complications can occur. Acute cholecystitis, which is inflammation and often infection of the gallbladder itself, usually caused by a persistent stone obstruction. Obstruction of the common bile duct, cholelithiasis, can lead to jaundice, cholangitis, infection of the ducts, or gallstone pancreatitis if the stone blocks the pancreatic duct outlet. Chronic inflammation can lead to scarring and dysfunction of the gallbladder. Rarely, a large stone can erode through the gallbladder wall into the adjacent intestine, usually duodenum, forming a cholecystoenteric fistula and potentially causing a bowel obstruction further down, gallstone ileosis, if the stone gets stuck.
Are bigger stones more dangerous?
Interestingly, small stones, gravel, are actually often considered more dangerous than large solitary stones because they are more likely to migrate out of the gallbladder and cause obstruction of the common bile duct or pancreatic duct, leading to cholangitis or pancreatitis. And importantly, the presence of gallstones over many years is the single biggest risk factor for developing gallbladder cancer.
Cholecystitis, inflammation of the gallbladder. You said it's almost always related to stones.
Yes, overwhelmingly. Over 90% of cases of acute cholecystitis are calculous, meaning they are precipitated by impaction of a gallstone and the gallbladder neck or the cystic duct. This obstruction leads to increased pressure, impaired blood flow, chemical irritation from concentrated bile, and often secondary bacterial infection causing inflammation of the gallbladder wall. It's the most common reason for emergency gallbladder surgery, cholecystectomy.
But there's also acute acalculous cholecystitis without stones. How does that happen?
Right, about 5–10% of acute cholecystitis cases occur in the absence of gallstones. This typically happens in patients who are already severely ill from other conditions, major surgery, trauma, burns, sepsis, prolonged intravenous nutrition, PPN, critical illness requiring mechanical ventilation, immunosuppression. The pathogenesis is thought to involve gallbladder ischemia, reduced blood flow, and stasis due to the critical illness and lack of oral intake, leading to concentration of bile sludge and mucus, chemical irritation and inflammation, sometimes without bacterial infection initially. It often has a higher rate of complications like gangrene and perforation because the patients are generally sicker and the diagnosis can be delayed as symptoms might be masked by their other problems.
And chronic cholecystitis, is that just from repeated acute attacks?
It can be the sequel to repeated bouts of low-grade or resolved acute cholecystitis, but it often seems to develop more insidiously without clear prior acute attacks. It's almost always associated with gallstones, present in 90% of cases, which are thought to cause chronic irritation and inflammation of the gallbladder wall, leading to fibrosis, thickening, and sometimes mucosal atrophy or metaplasia. Obstruction isn't necessarily required for chronic cholecystitis to develop. Clinically, patients often have recurrent episodes of biliary-type pain, though maybe less severe than acute colic, nausea, bloating, and intolerance to fatty foods.
The complications of cholecystitis itself sound significant too.
They can be. Bacterial superinfection is common in acute cholecystitis, potentially leading to empyema, pus in the gallbladder, gangrene, tissue death, or perforation, which can cause a localized abscess or generalized peritonitis. Fistula formation into adjacent organs can occur. Gallstone ileus is a consequence of fistula formation. In severely ill patients, acute cholecystitis can precipitate decompensation of other underlying illnesses like heart failure or respiratory failure.
Finally, gallbladder carcinoma. Not common, but sounds serious.
Yes, it's the most common malignancy arising in the extrahepatic biliary tract, but overall it's a relatively uncommon cancer compared to, say, colon or lung cancer. However, its incidence varies significantly worldwide. It's much more common in certain regions like South America, Chile, Bolivia, and parts of Asia. And within the U.S., it's higher in women and certain ethnic groups like Native Americans and Hispanics. The major problem is that it has a very poor prognosis because it's often diagnosed at an advanced, unresectable stage.
What's the biggest risk factor? You mentioned stones earlier.
Yes, the single most important risk factor is chronic cholestatic, gallstones. Gallstones are present in about 95% of gallbladder cancer cases. However, it's crucial to remember that only a very small percentage, perhaps 1–2%, of individuals with gallstones ever actually develop gallbladder cancer. So, while stones are a very strong association, they aren't sufficient on their own. The common underlying theme, whether from stones or other risk factors like chronic bacterial infections, for example, Salmonella typhi carriers, or parasitic infections common in Asia, appears to be long-standing chronic inflammation and irritation of the gallbladder mucosa.
So chronic inflammation is the key link.
That seems to be the consensus, similar to how chronic inflammation drives cancer risk in other organs like the esophagus, Barrett's, stomach, H. pylori, or colon, IBD. Genetic mutations, including those affecting the EGF receptor pathway, RAS oncogenes, and the TP53 tumor suppressor gene, are also frequently found in gallbladder cancer, likely accumulating as a result of the chronic inflammatory process.
What does gallbladder cancer look like grossly and microscopically?
It's predominantly adenocarcinoma, 90%. It most commonly arises in the fundus, the top or neck of the gallbladder. Grossly, it can present in two main patterns: as an infiltrating pattern, where the tumor diffusely thickens and hardens the gallbladder wall, often resembling chronic cholecystitis, making it hard to recognize, or as an exophytic or fungating pattern, where the tumor grows as an irregular mass into the gallbladder lumen, sometimes replacing the gallbladder entirely.
And under the microscope?
Microscopically, it's typically a moderately differentiated adenocarcinoma, forming glands or tubules lined by malignant cells, often embedded within a dense fibrous desmoplastic stroma. It's frequently invasive at the time of diagnosis, commonly showing invasion through the gallbladder wall into the liver or adjacent structures, as well as lymphovascular and perineural invasion, which are poor prognostic signs. Precursor lesions, including dysplasia and papillary neoplasms, are recognized, suggesting a possible stepwise progression.
Symptoms seem nonspecific, maybe overlapping with gallstone symptoms, leading to late diagnosis.
Yes, unfortunately, that's a major reason for the poor prognosis. Early symptoms, if present, often mimic those of benign gallbladder disease like cholelithiasis or chronic cholecystitis, things like right upper quadrant pain, nausea, vomiting, anorexia, weight loss. Jaundice usually occurs only later if the tumor obstructs the common bile duct. This overlap often leads to significant delays in diagnosis. Preoperative diagnosis is uncommon. Gallbladder cancer is often discovered incidentally during or after cholecystectomy performed for presumed benign disease, or it presents at an advanced stage when curative resection is no longer possible. Due to this late diagnosis and the aggressive biology of the tumor, the overall 5-year survival rate is very low, typically less than 10–15%.
Wow. We truly went deep there. We covered a tremendous amount of ground, from the fundamental microscopic ways the liver responds to injury and insult, through specific viral, genetic, toxic, and circulatory diseases, the complexities of cirrhosis and liver failure, all the way to the various tumors and the critical issues related to gallstones and gallbladder inflammation.
It really highlights the remarkable sophistication and interconnectedness of these organs, doesn't it? And how perturbations at any level, from a single gene mutation or enzyme defect to a viral infection or a lodged stone, can trigger a cascade of events leading to severe, even fatal outcomes. It also underscores the liver's incredible resilience and capacity for repair.
Yeah, that reserve is amazing.
Which paradoxically can unfortunately mask significant disease for years, even decades.
Absolutely. That silent nature of liver disease is striking. You can be harboring significant damage without knowing it, which makes the insights we've gained about specific risk factors, early lab changes, and the underlying mechanisms all the more vital for spotting potential trouble before it's too late. Really underscores the need for vigilance.
Which leaves us with a final thought for you to consider after this deep dive, thinking like the professionals who really master this information. How does the liver's unique ability to hide damage, its massive reserve, challenge us to think differently about routine health assessments, screening for liver disease in at-risk populations, and even how we interpret seemingly minor symptoms or lab abnormalities that might be whispers of a larger issue brewing beneath the surface? It's a powerful reminder, I think, that a deep understanding means appreciating not just the overt problems, but the subtle ways the body signals distress, or perhaps more importantly, sometimes fails to signal it until it's very advanced. Something to really mull over.